Good morning, everyone. I'm Kimberly Chalia with PHCA. Thank you so much for joining us for today's webinar, Five-Star Rating Changes presented by Deb Emerson. A few quick updates to share before we get started. This webinar is being recorded and will be made available on the PHCA website within the next 2 weeks. The webinar has been approved for 1 continuing education credit for all attendees. For those who provided an AB number, credits will be uploaded shortly. We'll also share certificates with those in attendance. As we begin today, all attendees will be in listen-only mode. Please feel free to submit your questions via the Q&A icon on your screen, and we'll make sure to answer as many of those questions as possible at the end of today's presentation. I'll now turn it over to Deb.
Great, thanks, Kimberly. I appreciate that. So we want to spend today talking about the updated staffing portion of the CMS Five-Star rating. And so as we think about what that looks like, this is just our standard legal disclaimer. So this is educational in nature and not providing any particular guidance for any facility. So when we talk about the objectives today and what we want to accomplish in this session is looking at the CMS changes to the Five-Star staffing requirements and how that Five-Star staffing is calculated now, and really how it plays into the overall Five-Star ratings. We want to make sure that we understand the whole calculation for the overall rating as well as the Five-Star rating. We'll use a couple examples to demonstrate the financial implications and looking at the changes in the staffing rating and some things that you can do at your facility or at least consider as we're looking at what those changes in the Five-Star staffing mean for your facility and trying to staff as we're dealing with all these workforce challenges that we're currently dealing with. And through the process, we'll go through what that Five-Star rating components are, how they impact the overall star rating, and what the old system looks like compared to the new system, and what changes we've already seen as of July 1st, and what we anticipate seeing in the future as we consider a staffing mandate coming out of CMS, and what some states are also using in their Medicaid programs. So to really understand the whole staffing, the Five-Star staffing aspect of the Five-Star rating, it's helpful just to start with a general overview of the Five-Star rating. So the Five-Star rating, I put the website on here. Hopefully you're all aware of where you can find this, but it's at the Care Compare website that CMS has out on the internet. And when it first was rolled out, it was really meant as a tool for individuals to go out and look at nursing facilities as they're trying to make decisions on what facilities to go to, whether they're going to a long-term care facility for long-term care needs, or they're getting discharged from a hospital for a short-term stay after an acute stay. It really provided an opportunity to do kind of that consumer comparison. When I think about Yelp or some of the other applications that are out there that you can rate different facilities, that's where the Five-Star rating started. It really has morphed into other usage. People are using it, CMS and various state Medicaid programs are using the quality metrics piece for payments and tying those payments and outcomes back to the quality measures. So we'll talk about that in a little bit. And the Five-Star rating is made up of 3 sections. So it's the health inspection, the staffing piece that we'll talk about in detail, and the quality measures. So when we look at that, the health inspection, that's really where the rating starts, and that's based on the outcomes from your surveys or the state health inspections. The staffing measure is based off the nursing home staffing level and staff turnover, which the turnover piece is new, and we'll get into the details of that. And then the quality measures are based off the MDS and claims-based measures. And so all of those play together to give you the overall Five-Star staffing. So how it's calculated, just to make sure we're all on a level playing field, is we start with the health inspection rating. And then step two is to look at your staffing rating. So whatever your health inspection rating is, if you have a 5-star staffing that is 5 or above, you can get 1 point added to your overall rating. And it's subtracting 1 star if your staffing rating is a 1 star. And then step three is to add on for the quality metrics. So you can add on another star if your quality rating is 5 stars, and then subtracting a star if your quality metrics rating is a 1 star. So obviously there's some caveats and there's some exceptions that are made to that. So if your health inspection rating is a 1 star, you can't go up more than 1 star to a 2-star rating, regardless of what your staffing and quality measures are. So you can't get a 1, an addition of 1 for both the staffing and the quality measure to get you to 3. You're not ever going to be more than a 2-star if your health inspection rating is just a 1 star. So when we look at the health inspection rating, it really is based, as I said, on your most recent surveys that happened during the last 3 years. And the most recent survey or the most recent rating cycles are going to be weighted more heavily than the older ones within that 3-year period. And so when you look at that health inspection rating, if you had 2.5, 3 years ago, a really bad survey, that will eventually drop off. And as you've made improvements in your facility, you're going to see that health inspection rating go up as you're making those improvements. So you get points based on the various deficiencies, and those are weighted again based off the rating cycle. And with the health inspection rating, it is based upon the performance of facilities within your state. And when we get into the quality measures and the staffing, that is based on national average. The health inspection is based off the ratings within your state, within Pennsylvania. So when you look at those points, what CMS looks at is those that are in the top 10% of those staffing or the health inspection ratings are going to get 5-star. The middle 70% are going to be those 2, 3, and 4-star facilities, and it's going to be equally distributed. And then the bottom 20% are going to be 1-star facilities. So when you think of that bell curve, regardless of the health inspection ratings, you're always going to see that bell curve in any one particular state. And then I'm not going to go into all of the quality measures that go into the quality measure rating, but just understanding that there are 3 different ratings that go into the quality measure calculation. So you've got your long stay quality measures, you have your short stay, and then the overall quality measure rating. So as you look at those, and they're both claims-based and MDS-based measures, those points are going to be assigned to each of those measures based off the specific outcomes. And what's interesting about these quality measures is they're not only used in the 5-star rating, but we're also starting to see them used in various Medicaid programs that are using them to tie Medicaid payments to outcomes. So some of those, particularly the long stay quality measures, are being utilized for various Medicaid programs for those particular add-ons. So we're seeing that, as well as the quality measures being used in the quality reporting program. So when you're looking at whether or not you're actively getting your 2% or not getting the 2% reduction, you're getting to keep that 2% for your quality measures, making sure that your MDS is completed, you're identifying those measures and it's getting completed on your MDS so that you're not impacting the QRP program. So just looking at this in total, it's not just about the 5-star rating and kind of that consumer look. We're starting to see a lot of various usages of the different portions of the 5-star rating. being used for payment. So as I said, the Medicaid programs, we also see quite a few of the Medicare Advantage programs are using staffing as well as the quality measures in setting their payment rates. So it's important to make sure that you at least have a general overall understanding of all of these and how they impact your facility. So now we're going to focus on the changes to the methodology for the staffing rating. So now that we have a good understanding of the overall picture for the 5-star rating, we want to walk through what the changes that happened on July 1st of this year and what they mean from a staffing perspective as well as the overall staffing rating. So we're hearing a lot of conversations are happening at CMS, in DC from a legislative perspective around staffing, the nursing home staffing and outcomes of the residents. CMS in the proposed rule back in April of 2022 talked about a minimum staffing mandate. They're studying that during this year. We anticipate some sort of proposed rule coming out early in 2023 around a staffing mandate. And so when we think about what is the impact of a staffing mandate on an organization, we also want to look at that the staffing portion of the 5-star rating and what's changed and what data is CMS using out of either this 5-star rating or the study that they're doing this year that might direct them on what they're actually going to do from a staffing mandate perspective. So when we think about the changes that happened prior to July 1st of 2022, there were only 2 measures that were used in calculating the 5-star rating. So we had the case mix adjusted total nursing hours per resident day, and we had the case mix adjusted RN staffing hours per patient day. As of July 1st, CMS has added 4 additional measures to the staffing rating. That includes the first 2 that have always been there. They're now looking at the case mix adjusted total nursing level on the weekend. They're looking at total nurse turnover percentage. So the number of nursing staff that have left over the 12-month period. They're looking at the RN turnover. So your percentage of RN staff that have left over the last 12 months. And then they're looking at administrative turnover or administrator turnover. So the number of administrators who have left over the last 12 months. And they're combining this all together to come up with what those staffing measures are. So where is that data coming from? And this, I think, is really important to understand that it's coming from that PBJ or the payroll-based journal reporting information. So every quarter, you're having to submit that information as far as the hours by discipline for your direct care staff. And they're also using the daily census information from the MDS. And again, when we think about the MDS and using that data, part of it is making sure if you have folks that have been discharged from your facility that you're doing a discharge assessment. Because if you're not, and those folks are there's still an active MDS out there without the discharge, they're included in that census that then impacts that case mix adjustment for your staffing levels per patient day. They also are using the MDS to case mix adjust those hours based off your case mix index on the RUG groups. So looking at a single quarter and case mix adjusting your PBJ hours based upon the CMI in your facility. What's interesting is there is the proposed rule out to update the MDS 3.0, where Section G is going to go away. So right now, everything is adjusted based on a RUG 4 grouping. So once Section G goes away and that is transitioned to more of the PDPM staffing measures from Section GG, CMS will have to release what that looks like. Right now, it's still based off of the RUGS 4 groupings for that case mix index. So that's where that information is coming from. The turnover measures still come from the PBJ data, and they're using the data from the 6 consecutive quarters of data. So what we're seeing, and as we get into some of the detail, is as people were starting to report their PBJ data and turnover hadn't been utilized in the past for the staffing rating, folks were not always making sure that it was 100% accurate when they were submitting their PBJ data. So what we saw with the rollout July 1st of this year with the new staffing rating is some of those turnover measures were much higher than anticipated or what's actual, because it just wasn't completed accurately on the PBJ data. So you cannot go back at this point and fix those 6 consecutive quarters, but we really want to make sure that as you move forward, that you're really paying attention to what's going on your PBJ submissions every quarter, and that you do some sort of review, whether that's internal or external, to make sure that that information is accurate before you submit it. Okay. So when we look at the specifications for the nursing staffing level measure, so we get lots of questions around what's included, right? So when we think about RNs, it's your RNs, your director of nursing, your DONs, and RNs with administrative duties. So when you look at the CMS technical user guide, these are the definitions of what goes into each of those different categories. Your LPNs are going to be your LPNs, LVNs, and those with administrative duties. And the nurse aides are going to be your CNAs or your certified nurse aides, aides in training, and your medication and technician aides. So it's important to make sure that you're including all of your facility employees that fit those definitions or those employee descriptions, as well as your agency or contracted staff. So we want to make sure, especially at this point where a lot of facilities are still having to rely on contracted nursing to fill their staffing needs, that that's getting captured appropriately on your PBJ data so that you're getting credit for those hours on the staffing level measures. And again, when we talk about the daily resident census, like I said before, it is coming from the MDS assessment. So looking at all residents of the facility at the beginning of the year prior to the reporting period. So for example, if we're looking at fourth quarter of 2021, they're going to be looking at the census data from October of 2020 through December 31 of 2020. So they're looking at that year of census to figure out who's been there, who's been discharged. And so they're looking over that time period and looking at those discharged, deceased residents to make sure that those get pulled out of the census, or any resident that has gone 150 days or more without an assessment. So those get removed out of the count for the residents for that specific day. So lots of changes, and I've gotten into a lot of details about what that all means, but what does it mean for the overall rating, right? So when we look on the left under the old system in calculating the overall rating, so you started with the survey rating, and then if your quality was a 1, you had to subtract 1 point. If your quality was 5, you added a point. For the staffing piece, if your staffing was a 1, again, subtracting 1, but under staffing, if you were a 4 or a 5-star staffed facility, you got a bonus or 1 point added to your overall rating. Under the new system, you only get that 1-star or that 1 point bonus if your staffing is a 5-star. So when we think about the implications of that when we got to July 1st and that rollout happened. So on the left side, again, looking at the old, we had a facility with a survey rating of 3. They were a 2, 3, or 4-star quality, so they didn't get any add-on bonus, but they were a 4-star staffing. And so they were bumped up overall to a 4-star facility. Well, all of a sudden, as of July 1st, nothing changed for them. So they're still a 3-star survey. They didn't get any bonus for the quality, but because they were a 4-star staffing, they lost that 1-point bonus. So we saw overnight folks going from 4 to 3-star when there was absolutely nothing different that was happening at their facility. So when we think back to, again, what is the purpose of the overall 5-star rating and looking at care compare? So if I'm a consumer and not truly educated on what does the 5-star rating mean, right? They just know 5 stars is the best, 4 is good, 3 is mediocre, right? And they're looking at that, and they've always looked at your facility as a 4-star facility, and all of a sudden you drop to a 3, and it's because of the staffing. They don't necessarily understand it's just a different calculation. They're looking at it saying, is there potentially something wrong with your facility? So it's important to make sure that your discharge planners from the hospitals, that you're communicating to your marketplace, that if you had a drop in your 5-star rating overall, here's why it happened, and that nothing has changed at your facility. You're still a 4-star staffing. You still have a good survey rating. So we want to make sure that we're communicating that, because the general public doesn't necessarily understand the calculation that's going on behind the scenes. So again, when we look at the old staffing rating and looking at the 2 measures that were used, so your total nursing and the RN staffing, and it was based off quintiles. So based off your case mix adjusted hours, you were put into one of 5 categories based off that, that distribution of your hours per patient day. So you had the total nursing across the top, the RN hours on the left side, and then where those intersected. So if you were a 1-star RN, but you happen to be a 4-star overall, you're going to be a 3-star facility. So it's that intersection of the 2. And so it was pretty easy to figure out where you were going to fall in those. You could do things differently from an RN perspective and how you were staffing RNs at your facility versus total nursing staffing to really figure out how you get into whichever star rating that you're working towards for your facility. And you could look at this and make those determinations. When we look at the new staffing rating, instead of those quintiles, so first off, we're looking at points instead of just focusing on the hours per patient day. So now we're looking at this, and with the 6 different measures, each of those measures get a maximum number of points. So your total nursing is going to get 100. Your total RN staffing, you can get a maximum of 100 points. The total adjusted nursing staff on the weekends is 50. And then your nurse turnover and RN turnover are 50 points. And your administrative turnover is 30 points. So those are the maximum amount of points that you can get. So 380 points maximum. And you can see up at the top, there are cut points for the number of points that you get. So if you're less than 155, you're going to be a 1-star staffing facility. If you're between 320 and 380, you're going to be a 5-star facility. So when we look at how do you determine the number of points? So now we're looking at deciles. So instead of breaking it up into 5 different categories or 5 different distributions, we're now looking at 10 different distributions. So for every percentage of your total nursing staff hours per patient day that you increase, you're going to get an additional 10 points. So for both the nursing and the total RN, you can move up 10 points every time you move into that new percentage category. And again, as I mentioned clear back at the beginning, this is based off national averages. So looking at a national distribution of these measures. For the weekend turnover, the nurse turnover or the weekend staffing, nurse turnover and RN turnover, you get 5 points for each category that you move up. And then the administrator, you get 30 points if you had no administrative turnover. You get 25 points if you had one administrator leave during the period. And if you had more than one administrator leave during the period, then you're going to get 5 points, or excuse me, 10 points. So you can see that it can really move, especially with the administrator turnover, it can move you quickly into different categories. So let me be a little more clear on what do I mean by these deciles, right? So it gets a little confusing, and if you're not a math person, I get it. So trying to understand, where do you get those points? So when we look at the total nursing staff, when I'm talking about moving up 10 points, so we're looking at your hours per patient day. So if you are between 0 and 2.7 hours per patient day for your total nursing staff, you're going to get 10 points for that particular measure. And as you move up, you go from 2.747 to 3.029, then you're going to get 20 points. So you can see that now you have this range in which you can work in and figure out how to use staff and still stay within a range to get whatever points that you're looking for that staffing component. Or if you want to move up or down, you can look at what are those hours per resident day that you need to staff to get to a higher point value for your nursing calculation. And the same thing holds true for the RN staffing as well as the weekend staffing. You see that minimum and maximum to be able to move you into one of a different category by moving up 10 points. So overall, what does that look like? This is just an example of a facility that we were looking at when this first rolled out July 1st. So when we look at this and we look at the dark blue line is our sample facility, the dark blue columns, their peer group. So when we look at a marketplace and we can compare them to those that are in their marketplace, that's going to be the light blue columns. So we look at each of the different 6 components, and you can see that this particular facility, their total nursing is between that 60 and 70%. So back to that previous slide, they're in this category of staffing between 3.6 and 3.868 for the residents that are at their facility. So they're staffing at that, and they're getting 70 points for that. And you can see the RN, they're getting 90 points. The total nursing on the weekends, they're getting 40 points out of the 50. The nurse turnover is 45, RN turnover 25, and they had no administrator turnover during the time period. So they got the full 30 points. So when we look at this and say, okay, as a facility, it looks like we're staffing really well, particularly the RNs in total. And it looks like we're doing a good job on the weekend staffing. So we're not quite to the maximum, but we're getting 40 points out of 50 for weekend staffing. And when we look at total nursing turnover, we're pretty good on that too, right? So we're looking at 45 points out of the 50. So if we're trying to make improvements and we're wanting to move up a star or to get additional points, what we would want to look at is, in this particular case, of what can we do over RN turnover. So pretty low at 25, only halfway up to the total number of points that you can get. So that would be an area of focus for this particular facility, is to look at how can they improve their RN turnover and get some additional points from the RN turnover. So again, this is just another way of looking at that. So when we look at this, on the left is what I just covered, and you can see when we're looking at that facility. So then we moved and made an adjustment then for the RN turnover on the right-hand side. We improved the RN turnover percentage, and so we were able to move them from the 4-star staffing. We got the RN points up by 10 points. So that moved them from a 4-star staffing into a 5-star staffing. So they didn't do anything different than changing the RN turnover and focusing on that. They didn't do anything different from their staffing perspective. They didn't do anything different from their RN staffing. So you can see that you can just make minimal changes and you get a difference happening at your facility. So it's a matter of focusing on what can you change and what is that impact of that change going to look like. So that's how you're moving the 5-star rating. But I want to talk a little bit about what are the financial implications, right? So a lot of different aspects of the financial piece can impact your 5-star rating, or the staffing piece of it. And when we think about it, we're looking at the overall rating. So when we look at that, and we're looking at referral sources, and we're looking at the number of admissions to your facilities, particularly in this very competitive marketplace, we're challenged with having enough staff. And so when you're looking at admissions to your facility and trying to make a decision on, do we hire agency staff? Do we have enough employees that are available that we can hire to take on new admissions? Can we do that? If you're looking to market to your referral sources, to the hospitals and the physician groups, what is your story that you're telling those referral sources? And are you able to communicate to them that you're a 4 or a 5-star facility, and what that means to them, what that means for the residents and the outcome of the residents that are at your facility? And it's important to have those conversations. Part of it is also around the type of residents that you're taking in. So remembering that all of those hours are case mix adjusted. So when you're looking at it and looking at your admissions and looking at the type of residents that you're bringing into your facility, are they the high acuity residents? And you're going to have to staff differently for those higher acuity residents versus the lower acuity residents. And what is the impact on staffing, and what is the impact on your star rating to do that? As I mentioned earlier, some Medicare Advantage programs also look at the 5-star rating when negotiating rates. So that may play a factor as you're looking at contracting with some of the Medicare Advantage programs. I know that that's continuing to grow, and there's concerns in the marketplace around, are Medicare Advantage programs paying enough? Particularly as we get residents who are sicker, and we have those Medicare Advantage programs that are looking at shorter lengths of stay, and maybe not paying as much as they should for those higher acuity residents. So it's always important to know what is being included in those rates and what can you impact on those rates, whether it's the 5-star rating or other quality measures. We also have other payer sources. So we're seeing a growth in I-SNPs, or special needs plans, and they may tie a portion of those payments and coverage to 5-star rating overall. So we want to make sure that we understand how those payments are being tied to your 5-star rating. And that's going to be very individual per whatever contract you're in or what the ISNP contract is. But making sure if you're in any of those arrangements that you do understand if the 5-star rating is being used and how it's being used. The other is potential penalties around the staffing mandate. And I talked about that at the beginning with the staffing minimum mandate that CMS had put in the proposed rule back in April. And we don't know where CMS is going to come out with that yet. And there likely won't be penalties, but it's also likely that it's going to be an unfunded mandate, right? And so when we think about how are we going to staff to a minimum staffing level, and what is the impact of that minimum staffing level on the 5-star rating, I think that trying to correlate those and making sure that you understand what the implication is for your facility. So we already have facilities across the country, and as well as your own state in Pennsylvania, that are declining admissions, turning away admissions because you don't have the staff available to take care of those residents. And so we, as organizations and facilities, we want to make sure that if we're bringing someone into our building, that we're appropriately staffed to meet the needs of those residents and to provide them the best care and to get the outcomes that the residents are looking for and that we as organizations want to provide. So if you can't meet those staffing minimums, that's going to be a challenge. And when I think about like 1-star staffing facilities, it's case mix adjusted, you're looking at hours per patient day, how are those facilities going to staff differently, admit folks differently? What is that strategic thought process going to be as you move from it just impacting your star rating to having a staffing mandate that you have to meet? So what is that going to look like? That is still to be determined. I think we'll have a much better idea of what that all looks like and how we talk about that in early 2023, but just something to consider for your facility. And then finally, when we think about the financial implications, is what is the cost to staff at a 5-star staffing? It's, again, back to that public perception. And when we talk about our mission and what we're trying to communicate to our partners and to the folks that are in our buildings, especially some of those that may be in life plan communities, and you're looking at getting folks in your independent or assisted living that may eventually get into your nursing facility, and they're looking at that. What does it cost to staff at a 5-star? How do you make that determination? What are things that you need to look at? So I'm going to walk through some examples of all of these and how do you really look at it and how do you tell your story? So going back to the first bullet point on the last slide, when we talk about that star rating compared to your peers, and when you're telling the story to your marketplace and to your referral sources. So in this particular slide, we've got this, we have this facility right here. That's our sample facility. And the rest of them are just peer groups, whether they're in the marketplace or a facility has, said, I want to know how I compare to each of these other 5 facilities. We can look at that and say, okay, your facility is a 4-star facility. But we also look at when we're talking about telling that story. So you may be a 4-star staffing, but your readmissions to the hospital or your ED visits of your residents are pretty low. Compared to this facility number 1 in the brown column, yeah, they're a 5-star staffing, but their readmissions to the hospital are pretty high. This red little square at the top, diamond at the top. Their ED visits are still pretty comparable, but you can see that they're readmissions. So it all becomes about how do you tell a story. Just because your staffing is 1 star lower than your competitors doesn't mean that the outcomes are better. And so you really want to look at that whole story and how do you tell that story and how do you tell the meaning behind that. So being able to do some of those comparisons and lay those 3 kind of data points out to your referral sources is really important. The next thing we do when we talk about the cost of staffing at a certain level, and we use the PBJ data, so your actual 5-star calculation and the points that you're getting, and the case mix index from that PBJ or the MDS data. And then we're looking at the hourly rates that you're paying for that direct care staff. And so we look at this, and on the left is the current staffing measures for this particular facility. And the blue columns are the facility that we're looking at. The brown column is the market. So what are we seeing in the market? And where, if we're trying to improve and to get up to market level because we think that's what it's going to take to be successful in the market, how are we going to get there? So we look at this and look at how we compare. Do we need to make improvements? And what is the cost of making that improvement? Or in this particular case, we looked at it and said, okay, this facility, they're getting 60 points for their total nursing, so they're in that 60th decile. They got 70 points for their RN, so they're doing pretty good. They're not quite at the maximum of the market, but they're doing pretty good. Their weekend staffing's comparable. They actually have great nurse turnover, so they're getting pretty high points for that. And then they're comparable with their RN and administrator turnover. So we look at this and say, okay, from a market perspective, you're staffing at a 4-star, your overall rating is 2. You could staff differently, and it would really come in the total nursing staffing to get to a different move up to the 70th or the 80th percentile to get 10 or 20 additional points. Or you could stay at the 4-star staffing rating and the overall rating of 2, but maybe you make some adjustments within those parameters that keep you at that level, but you don't spend quite as much money on staffing. You can do something different and shift maybe scheduling or who you're scheduling, or even the mix of residents in your facility. So we look at this, and you can see here at the bottom, we've got 288,000 as savings. How do we figure that out? Because we didn't do anything different. You're still at a 4-star staffing. How do you save 288,000? So again, it's looking at what you're paying per hourly rate. So here's the 288,000, this dark blue right here in the middle. So we're looking at where you're at on the top bar for total nursing hours. The left is your RN hours, and then the bottom is the weekend hours. So what are you paying to get within those parameters? And remembering back to one of the earlier slides where you've got that range, the minimum and maximum of hours per resident day. Well, in this particular case, based off what they're paying, they could reduce their hours per resident day and still stay within this little box here and spend 288,000 less on staffing without moving a star level. Now, if you want to make some changes, and you can see any of these positive numbers means you're reducing hours per patient day, either total, RN, or your weekend hours. So how you shift the combination of those and how that changes the points that are awarded gives you an idea of how you can have some cost savings. On the reverse side, if you want to move up to a 4-star facility, or from a 4 to a 5-star staffing, then we start looking at what is the cost of that. So if you wanted to get all of your total nursing hours per patient day, your RN hours per patient day, and your weekend hours per patient day, all at those maximum points, you're talking 1.6 million, almost 1.7 million to get to that level that you would have to spend in addition to what you're spending today. So it becomes an exercise, again, of trying to make those decisions of where do you spend the money, where can you save money, and what star level do you want to be at? So when we look at all of this, it's all a math problem, right? And so understanding how those hours per patient day are calculated, where you fall in those deciles in each of the 6 categories, and what do you need to do to staff differently to move up or down, and what is the cost of that staffing differently to move up and down. I will tell you that all of this, when we saw the change July 1st, we saw a lot of facilities that dropped either overall because they were a 4-star and they stayed a 4-star and they lost that 1 point, or we saw folks that dropped a star level. It doesn't matter what star level they were at for staffing because of the turnover piece that was added to the calculation, to that 5-star staffing. So we saw a lot of movement in the star ratings as of July 1st. And so that has, created questions. What do we need to do different? Is there anything we need to do different? But also about the messaging around the changes. So it's important to understand that. So we look at this and we try to tie this into what is CMS looking at, right? From the staffing mandate, if you're staffing at 3.5 hours per patient day now and you're at a certain star rating for that, if CMS comes out with 4.1 hours per patient day, what does that mean for your facility? Is this going to be something that's going to cost you $750 or $850 or $1 million to get to that level? That's something that each individual facility is going to have to look at and say, what is the cost? What does that mean for my admissions? And what do I need to do different? And how are we going to approach that? So I know that was a lot of information today and a lot of math type information. I will open it up. If there's any questions, as Kimberly said, please put those in the Q&A. I'm happy to answer those questions.
All right, wonderful. Thanks so much, Deb. That was some great information. I'll open up the Q&A channel now. I do see somebody wrote an anonymous comment asking if the slides will be available. I'm happy to send those over to you if you just want to shoot me an email. Unfortunately, I can't pull up your email because it's reading that it's from anonymous. So if you wanted to email me, my email is linked here in the chat. And if anyone else has any additional questions, feel free to ask at this time.
And I just, as people are thinking, Kimberly, I wanted to just, I put my contact information and it's in the slide deck and it'll be in the recording. If you have any questions that you think of after the presentation, or you want to walk through your particular facility's star rating and how did it change, if it changed, and what does that financial impact look like, please reach out to me. Please reach out to any of our CLA team in our Pennsylvania offices. More than happy to help you out.
All right, thanks so much, Deb. I see a couple people posting that they would like me to send the slides. Happy to do so. Yeah, and if there are no additional questions for today's session, I can end that here. Please, please, please feel free to reach out to myself and or Deb if you have any additional questions that arise after today's session. Thanks so much, everyone.
All right, thank you.
Thank you.